Yeah, Laura. Laura. Hello, good evening, everyone. Thank you for joining us. Please confirm that you can hear me. Anyone, can you confirm that you can hear me? Can anyone confirm that you can hear me? Okay, yes, thank you. Thank you. I read your chats. Yeah, good evening. Thank you, everyone, for joining us this evening. My name is Obina, and I'm the Learning and Development Coordinator at EHA Clinics. This evening, we'll be bringing you another very interesting edition on our educational series. And today, we'll be looking at the role of pharmacists towards education on antimicrobial resistance and stewardship. I'm sure you will agree with me that this is an all important topic. And our guest today is pharmacist Opalako Onyinye. Right. So from our guest is pharmacist Onyinye Opalako. She's a graduate of the University of Nnamdi Azikiwe, where she obtained a bachelor's degree and also a master's degree in pharmaceuticals and pharmaceutical technology. She's currently the head of pharmacy unit at the Anglican Hospital, Kubwa, Abuja, Nigeria. Her research interests are clinical research, pharmaceutical drug delivery, and nanomedicine. A pretty impressive resume, I would say. Right. So to get us started, I hope we understand some of our rules, and it'll be that we wouldn't want to take any of your questions or interruptions. I'm sure you would have noticed that your ability to raise your hand is not enabled at this time. But as we go on, if you have questions, if you have comments, if you have whatever comments you want to make, you can use you can use your Q&A section for your question and answers, and then of course any other comments can be on the chat box. I would also recommend that you share the links. Yeah, you share the link to the webinar, maybe to everyone that you know around anywhere. I'll quickly drop the link on the chat box. So if you have pharmacy colleagues who haven't joined, maybe you can just share this link with them. We're also streaming live on YouTube as we speak. I'll also share that link with you so that you can help us, communicate this to whatever guests we have there. So good evening, Farm Lillian. Can you hear me? Laura. Hello, Farm Lillian. Can you hear me?
Good evening. Thank you very much. Thank you.
Yes.
Yes, I can hear you. Good evening.
Yeah, good evening. So I want to share your screen. Or would you attempt sharing your screen, and let me see if it'll work from my end so that you can better concentrate on the presentation. Okay, I got it. I got it. All right, thank you, Family. Please, you can have the floor.
Yeah. Good evening, everyone. I'm so honored to be here today, and I appreciate the panelists and the management of EHA Clinics for the singular opportunity. Um, it's a privilege, really, and there's a lot we need to talk about tonight in the short time we have, and I hope you do have a great time. I'll be willing to respond to all of your questions. So I'll just be taking the slides one step at a time, and then we'll take it from there. So the topic before us here is the pharmacist's role, the role of pharmacists in antimicrobial resistance, education, and stewardship. So this is a topic that deals with the role pharmacists play regarding things, being microbial resistance, and education, and the AS and antimicrobial. In of the slide, I'll be a lot of yes, just to note, AM means antimicrobial resistance, and MS antimicrobial word.
Hello from Lillian, are you there? We lost you. Hello?
Yes, in the slide. Okay,
Hello?
so an overview of what we need about today, and hear you. Please, can you all hear me?
Yes, can you just turn off your video? Maybe it will reduce the
Can we hear me, please?
yes, I heard you. Yeah, yes, please go on it.
Okay, right. Okay, so an overview of what we need to talk about. We'll be talking about the landscape of AMR, pharmacist's pivotal role in AMS programs, strategies for educating health professionals and the public about AMR, and collaborative approaches to combat AMR at global and local levels. So the presentation will kick off with a short story. I believe will set the line for all that we need to talk about today. Like everything we need to talk about today is just centered on the story of Ralia. So I'll just take that part. Ralia is a 32-year-old lady who presented to the hospital with symptoms of cough and was diagnosed with respiratory tract infection. Now, Ralia had been consuming multiple antibiotics as advised by her aunt. It will shock you to know that her aunt is not a medical personnel, just her aunt. Do you mind showing us the slides so that we can read together? So Ralia had been consuming multiple antibiotics as advised by her aunt in the last 2 weeks. So upon successful initiation of appropriate antibiotic therapy by Ralia's doctor, after an appropriate lab investigation, Ralia was fine. So 5 months later, Ralia developed a cough. What happened? Ralia hurried to the nearest drugstore or pharmacy and she purchased the exact antibiotics her doctor had earlier prescribed. However, her symptoms only got worse as she could hardly contain the breathing difficulty she experienced. The last resort was to revisit her physician. So some lab tests were done, and it was confirmed that Ralia's case was that of antimicrobial resistance. Why? Multiple drug failure. And this was due to drug abuse. Ralia was in the habit of taking antibiotics that were not prescribed by her doctor. It leads us to talk about what antibiotics are. I don't want to assume we all know, but let me just do the introduction. Antibiotics, the word antibiotic signifies against life. Bio represents life, and anti means against. So an antibiotic is any medicine that kills microorganisms or what we call germs. And generally, antibiotics fight infections caused by bacteria in humans and animals. How do they do this? They exert bacteriostatic actions and they exert bactericidal actions. Now, what are bacteriostatic actions? These are actions that are not necessarily killing in effect. What they do is that they halt the cellular processes of a bacteria. What that means is that they inhibit the growth and multiplication of bacteria. while bactericidal effects are actually the killing effects of antimicrobial agents. Okay, so what is drug abuse? Before we delve into antimicrobial resistance, I feel we need to talk about this. Drug abuse, which is the use of illegal drugs or the use of prescription or OTCs for purposes other than those for which they are meant to be used or in excessive amounts. Drug misuse is defined as the use of a medicine for a purpose not consistent with guidelines. Um, Now, drug misuse, drug abuse, overuse, underuse, all of them all come under the problem of drug abuse, and they come with a lot of consequences, which we will see as we proceed. Now, there are startling statistics that talk about the prevalence of some of these antibiotic use. It was shown in a study that was carried out in Nigeria that the prevalence of antibiotic abuse amongst hospitalized patients range from 62.4 to 78.2%. Now, at the community level, that's in community practice, people who just walk into stores and buy drugs, it was documented that up to 75% of antibiotics in both human and animals have unproven clinical relevance, meaning that they were drugs that were taken but were not necessary. So, according to the CDC, Center for Disease Control and Prevention, about one third of antibiotics used in people is not needed rather, nor appropriate. So total and inappropriate antibiotic use, inclusive of unnecessary use and inappropriate selection, dosing, and duration, may approach 50%. Now, what is even more shocking to me is the fact that this is very prevalent in low and middle income countries. I was thinking that in undeserving communities, like in low and middle income countries, the statistics should be lower. But it shows that people are willing to invest into buying drugs even when they are not needed, all in a bid to get well, of course. So, antimicrobial resistance, we want to talk about this now, is one of the biggest challenge with antibiotics abuse. If you don't mind, could you help me show the slides? I think we've gone past the stage. Yeah, thank you. So, antimicrobial resistance is a leading health menace in the 21st century. And this happens when fungi, and I want to bring something to our knowledge. When we talk about antimicrobial, the word microbe refers to not just bacteria. We are also talking about viruses, fungi, parasites. All of these come under microbes. So it's a class on its own. So AMR happens when these microbes mutate, or what we call change. There's a change in their DNA and they become less susceptible to existing treatment. What that means is that they become less sensitive. For example, amoxicillin is supposed to sort out this microorganism, but for some reason, due to mutation, this microorganism finds a way to circumvent the effect of the antibiotic being amoxil. So you see people take these drugs and it's like they are not working. It's as a result of antimicrobial resistance. Now, bacterial antimicrobial resistance is the large portion of what we're talking about today. And it happens when bacteria, like we said, undergoes genetic changes that makes them less sensitive to elimination. The WHO has reported that 4.9 million deaths annually is associated with AMR globally. And the burden of these drug-resistant infections weighs heavily on low and middle income countries. Now, just some clinically important examples of this issue of AMR are microorganisms like methicillin-resistant Staphylococcus aureus. Now, Staphylococcus, we know, of course, it's a bacteria, but there are strains of it that mutated and became resistant to certain antibiotics. Now, this particular strain of S. aureus is resistance to methicillin. And it's of clinical importance, of course, because this condition has defied a lot of antibiotics, save a few. Now, we also have vancomycin-resistant Staphylococcus aureus, we have Clostridium, and we have Neisseria species. That's the causative organism in gonorrhea. We also have gram-negative bacteria. There are some gram-negative bacteria that are resistant to the effect of antibiotics. So they come under a class of their own. Now, you might be asking yourself, how do these microorganisms affect resistance? How do they become, if I should use a layman's word, how do they become stubborn, like they are not affected by the effect of antibiotics? This is what happens. Now, we all know that these microbes are living organisms, and one thing we know about living organisms is that they try to adapt. Adaptation is key for microorganisms, living organisms generally, microorganisms inclusive. Now, when even for a human being, a normal human being, when an attack, possibly an attack was launched on a human being, if the same attack is wanting to repeat itself, the normal thing for the human being to do is to try to resist. Or sometimes when they cannot, they try to adapt. You understand? So there is a way that these microorganisms find a way to put up defense mechanisms against the attack of the antibiotics. Now, they do this through different mechanisms. Now, it will interest you to know that some of these antibiotics have different points of attack on the bacteria. Some attack the cell wall, some attack cell division, some attack multiplication, some attack the enzymes that are necessary for the survival of some of these bacteria. Now, we have first on our list is drug enzymatic inactivation. Now, what happens is that the bacteria, which mostly are gram-positive and negative, they produce what we call beta-lactamase. What this beta-lactamase does is that it tries to degrade the effect of the drug, some mostly penicillin antibiotics. Now, because of this, scientists had to come up with a drug that contains what we call clavulanic acid, clavulanate, which inhibits the effect of some of the beta-lactamase effect of some of these antibiotics. Now, we have decreased antibiotic permeability and efflux. What these antibiotics do is that they penetrate the cell wall of these bacteria and inhibit cell division. They inhibit normal mitotic division, everything the bacteria needs to stay alive. Because for bacteria to survive, they need to keep multiplying. That's what keeps them in the process. Now, some of these antibiotics, they penetrate these cell walls and they inhibit these processes. Now, because of resistant mechanisms, these bacteria, what they do is that they find a way to pump out the antibiotics. They put up defense mechanisms against the permeability of these antibiotics, such that the antibiotics are no longer soluble. This happens in drugs like tetracycline and fluoroquinolones, examples ciprofloxacin and the likes. So these drugs become less soluble and they're not able to penetrate the cell walls of bacteria. So in this case, the drug is assumed not to work. Okay, so key accelerators of antimicrobial resistance, we have microbial. This has to do with the transfer of the transfer of this mutation process they carry. It's like it's in their genes, so they find a way to transfer it to other species. Now we have antimicrobial misuse and abuse. All these things accelerate resistance, self-medication, unnecessary drugs that are not needed. I have simple cough, I go and take antibiotics. Knowledge gaps also. Some people really do not know. They are not aware that there are data, statistics, and trends that are being published daily. Agricultural consumption. Now, this is a very important factor, especially in developed countries like the US. You see that in most livestock feed, they put antibiotics into them. And sometimes some of these antibiotics, they may not even get a prescription from a vet. They just add it. Even here in Nigeria, people do it as well. They just add antibiotics into the feed of this livestock. So also conflicting interest due to financial gains. What does this mean? Because this particular antibiotic, if I buy it more, I tend to have gains. So let me keep buying it and prescribing it. And I'm not concerned that there could be resistant issues because I keep prescribing the same antibiotic. Lack of adequate follow-up. Sometimes our patients needs people to follow them up. Be aware that they should finish their antibiotic. So in some cases where these people are on chronic intake, like people who are taking these things for quite long, they need to be followed up. Now, lack of proper laboratory investigation system. Sometimes there is a lack of laboratory setups in some communities. So some people, because of the inconvenience of where will I find a lab to do my test, let me just buy antibiotics and take. And they end up abusing these things because they are easily accessible. And now that leads us to the last point here, says poor quality and easily accessible antibiotics. Other accelerators of antimicrobial resistance, we have lack of stewardship training, the need for novel antibiotics. We know that it takes a lot to produce a drug. So sometimes the rate of resistance and the rate of abuse and the rate at which some of these drugs are returned back to the shelves is overwhelming compared to the quantity of new antibiotics that are brought into the system. Poor pharmaceutical counseling. Sometimes we as pharmacists or we as healthcare providers, we just give these people their drugs. Ciprofloxacin, okay, take it morning and night, just like that. But if you actually counsel the patient, this is why you're taking this antibiotic, this is why you need to finish it, please finish your antibiotic, and you actually follow up on them, because sometimes they do not know. So the last part is a clinically related problem, which is inadequate understanding of the pathogen drug combination. Now, for methicillin-resistant Staphylococcus aureus, there are antibiotics that are unique to this particular strain of Staphylococcus. There are antibiotics that are unique to MDR-TB. What this means is multi-drug resistant TB. So people should not just give antibiotics at will because you feel like, okay, let me just give and see what happens. If it doesn't work, we change. That's polypharmacy. So challenges of AMR. There are a lot of challenges that comes with this menace. Number one, infections become very difficult to treat. You see someone has URTI, upper respiratory tract infection, and the person takes amoxicillin, it's not working. The person takes cefuroxime, it's not working, And if you do a background check, you notice that sometimes these people have abused these things and it becomes difficult to treat. And it could lead to death in some cases. Decreased capacity to fight off infections, especially in immunocompromised patients, patients on dialysis and chemotherapy, because there is continual abuse of these things. It poses a very lethal effect, even on the helper cells, like the immune cells in the normal human system. Now, limited alternative therapeutic options. Because the patient, for example, has abused a lot of antibiotics, like in the case of Ralia, the doctor is actually constrained. He doesn't really know, what do we do with this case right now? Because going to the lab, a lot of antibiotics, resistant. So there are limited options. High financial impact. So you see people go for things like Rocephin because something as simple as ciprofloxacin, simple, affordable, and effective, or that should have worked, but it's not working because of abuse. What are the recommendations? Recommendations are surveillance systems. I bet you if we're not intentional about how we're going to put surveillance, how we're going to watch, how we're going to inspect and carry out pharmacovigilance feedback systems, and get information of how these things are meant to be done, there's likely going to be problem. And also, I believe so much in people enlightenment. And I believe as pharmacists, as healthcare providers, we should be very, very up in our game in enlightening people regarding the use. The truth is that sometimes people do not know. And even if they know, they do not have the complete knowledge that these things, this issue of going to a pharmacy, you can buy these things easily, you are killing these antibiotics. And it's not just for the system, it's also for themselves. So people need to be enlightened. Self-medication. You need to talk to people about self-medicating, that it's not proper. Unnecessary administration, drug not needed. We've talked about this. Inappropriate dosing. Sometimes people take doses that are not complete. When they feel like they are fine, they abandon the rest. So when the doctor prescribes, take your antibiotic for 5 days, for 7 days, some people do 3 days, they are fine, they abandon it. So these are things that we should inculcate in our patients. We should try to talk to them. Also, there is a lot that we need to do as regards antimicrobial stewardship, which we shall talk about later. Now, antibiotic dispensing reforms, just the same way we have records of some of our control drugs for pharmacists, some drugs we dispense and we take records. It will do a whole lot of good if we have antibiotics or label some antibiotics as POMs. What are POMs? Prescription only medicines. Drugs like drugs that need to be protected. Some really, really sensitive medicines that need to be protected and not to be found anyhow on the shelves that people can access anyhow. I think it will go a long way. Now, regulation against agricultural use of antibiotics. There should be regulations. People should not just walk into pharmacies and say, I want to buy amoxil capsule, and they are pouring it into the chicken feed or goat feed or whatever. There should be regulations regarding the use of this. And this brings us to the second part of this presentation, and that's antimicrobial stewardship. It has been reported that multi-drug resistant bacteria kills about 700,000 people globally in a year. Now, what is antimicrobial stewardship? Now, they are clinical interventions. Mark my words, they are interventions designed to enhance the right selection, the right use, the dosing, the duration, and route of administration. All of these come under stewardship. Now, AMS programs aims to preserve antibiotics from abuse, misuse, and you see people, maybe patent medicine, strictly health professionals end up prescribing a lot of a particular kind of antibiotic. They don't even there's no need for tests. They just keep prescribing. But once there are AMS programs, stewardship programs, interventions, which we are going to talk about, so you're going to understand what I'm saying, it's going to reduce local disease spread. If there's an outbreak, it's going to curtail on it, because AMS programs help to, they are regimented programs, they are tailored programs. So they don't just address a group of people, it addresses a unique patient population. And also, it will help to reduce financial impact. So stewardship programs are actually cost effective. What are the goals of stewardship programs? To practice the 5 Ds of antimicrobial therapy. What are these 5 Ds? We're going to talk about them. To prevent antimicrobial overuse, misuse, abuse in inpatients, mark my words, I said inpatients, meaning this can be practiced also in the hospital and the clinic settings. Outpatients, also for those in the community pharmacy, I mean, and also in the community at large and the agricultural industry. Now, another goal is to reduce antibiotic related adverse effects. This is something we are not talking about. People do not know that this stewardship programs is not just because I want to prevent resistance, so let me protect it. No, there could be adverse effects of taking multiple antibiotics and for no indication whatsoever. For example, Clostridium difficile. There are adverse effects that have been reported with the germ Clostridium difficile, and it even becomes worse when people abuse antibiotic, or the antibiotic that is not meant or is not sensitive to the the bacteria Clostridium difficile. Now, to minimize resistance and preserve antibiotics, we've talked about that, and to reduce healthcare costs. Now, what are these 5 Ds of antimicrobial therapy? Antimicrobial stewardship. We have right drug. That's the first D, the right drug. There is nothing as sweet as the right drug. It's like fitting a key into a padlock. Getting the right key for a padlock. Just imagine that situation. And you're not just getting a lot of keys and you're trying anyone that goes through. No, no. It's a waste of time. It's a waste of resources. It's a waste of energy, and it's a waste of intellect. And sometimes, because the clinician is under pressure, sometimes the clinician is under pressure, this patient needs to get better. So the time to wait to actually see, to run tests to be sure that this is the right drug, sometimes people are not that patient. But there's nothing as beautiful as giving the right drug, tailored drug for the right antibiotic, the specific antibiotic, I beg your pardon, the right dose. Dosing systems, as pharmacists, we need to understand it. Um, the appropriate dose for giving a drug like cefixime may not be the same if it's a case of URTI or if it's a case of tonsillitis. These things are different. And this is very important when we're dealing with IVs. When you're giving a drug like ceftriaxone IV. Now, why will you give ceftriaxone IV, for example, now, 1 gram to a child of maybe 3 years? Maybe the child keeps presenting with recurrent tonsillitis. Now, there is a path for the right dose. You may want to query what I just said right now. Like, why will you give 1 gram? It's too much. Is this, is this. But certain disease conditions require that certain doses be increased. And there are certain disease conditions that requires that certain doses be decreased. For example, in elderly, the disease condition. So there's a lot that comes into play. And this is where antimicrobial stewardship comes into action. The correct drug route. Now, you may want to say, what is route doing in this? It's also very important, because the dose of the drug you give through the IV, of course, we all know is not the same as the drug when it's tablet. We all know flagyl infusion is 500 milligram, but in the tablet form is 400 milligrams. So you won't say because it's 500, let me try to balance it together. Because there are different routes, the dosings will be different. Pharmacokinetics is going to come into play and all of that. So correct duration. Duration is usually a problem. And that's the reason why we as pharmacists, as healthcare providers, we must be on our guard to ensure that our patients actually finish their course of antibiotics. You see a lot of them say, I'm tired, like, I'm okay now. No, please always encourage them to finish their course of antibiotics. Timely de-escalation to pathogen-directed therapy. Now, this is a very important part. We'll talk about it in the next slide. De-escalation, like the word de-escalation, it deals with how you're able to tailor an antibiotic therapy or a course of antibiotic from broad spectrum, or when they treat empirically, to a more direct therapy. In other words, you can say antibiotic de-escalation refers to directed therapy. Now, what is this term? What is it about? It's a critical part of antimicrobial stewardship, because it helps to converge the physician's approach to prescribing antibiotics, especially when multiple antibiotics are prescribed. For example, when there is need to treat empirically. What is treating empirically? It's like saying that we're not sure which particular germ is implicated in this patient's disease condition. So let's just treat empirically, pending when laboratory investigations are released. This is what we call treating empirically. Or in some cases, when it's a case of sepsis. Sepsis, we know, is a life-threatening condition, so there's really no time to waste. So most times, physicians tend to give antibiotics that are BS, broad spectrum, just to keep the patient going, because we know laboratory results may not be ready till maybe 48, 72 hours, as the case may be. So to keep the patient going in life-threatening conditions, they prescribe BS antibiotics. So what does antibiotic de-escalation do? It helps to streamline antibiotics from broad spectrum to narrow spectrum. Why? Why do we do that? Because over time, you keep giving broad spectrum antibiotics, there's a lot of indication that will come in if you keep doing that over a prolonged period. Quite all right, that will help to kill all the bacteria implicated, no. But over a long period, that may not be feasible. You can do that when it's a more narrow spectrum antibiotics, specific implicating germ. Now, I've already talked about this, that patients under intensive care, those comatose patients, they have increased risk of sepsis. They could come down with serious mucosomial infection, bacterial infection. So there's usually need to do a step down, or what we call a de-escalation from a broad spectrum to a narrow spectrum. Now, this is increased use of antibiotic. Sorry, let me just read what I wrote here. It said increased use of an antibiotic increases resistance to that class of antibiotics. You see, so what that means is that if I keep using a particular antibiotic, the resistance chances of resistance are increased compared to when I have it streamlined to a particular antibiotics. Now, in ADE, or what we call antibiotic de-escalation, a broad spectrum exposure is narrowed to decrease the empiric antibiotic load. For example, we have a patient, a comatose patient, and we've done some laboratory investigation, and this person is having septic conditions, and we really need to attack whatever it is. In such cases, a broad spectrum, the physician might want to do this, but over time, after 48, 72 hours, when a particular germ is isolated, it is now streamlined, and it is done to reduce the empiric antibiotic load. Benefits of ADE: stoppage of antimicrobial actions for pathogens unidentified. Now, remember that this initially we started with broad spectrum. So it ends up killing a lot of antibiotics, bactericidal actions on a lot of antibiotics. So sometimes it can even interfere with the microbiome, or sorry, let me use the word like microflora, both helpful antibiotics that are found in the human body. It could help eliminate all of them, and that's bad. So we streamline this therapy to reduce some of these effects. And sometimes, if we do not apply antimicrobial stewardship through ADE, it could lead to what we call dose dumping. What is dose dumping? Because there's no antimicrobial stewardship, there's no lab test, let's just keep giving the broad spectrum, let it kill everything. You see that sometimes there's risk of what we call dose dumping. It even happens with oral therapy. You see people keep taking oral therapy of a drug because it's broad spectrum. They keep taking it, let it kill everything in the Nigerian parlance, but that's bad. It could also lead to drug interaction. Remember, we started with a broad spectrum of empiric therapy. So you see 2, 3 antibiotics being given. There is risk of drug interaction, there's risk of adverse events. So these are things we try to reduce. And sometimes it's even difficult for the pharmacist to do what we call therapeutic drug monitoring, because you have a load of antibiotics. So if there's any risk of interaction, you're not easy, it's not easy to identify the one that is implicated. Reduction in hospital stay, because we're able to identify the particular germ and you're able to streamline your therapy, the patient gets better, goes home, and that's the end of it. Unintended drawbacks: there is extension of antimicrobial course, undue exploitation, sometimes because I've explained this before though, inadvertent misuse of broad spectrum antibiotics. I've explained this. Now, what are the recommendations? For example, in undeserving communities, there is always need for a robust laboratory system. so that once we are able to identify the causative organism, and even we will even advocate the use of rapid diagnostic tests. For example, I need to do full blood count. Do I need to wait for 72 hours or what? How about having test systems that can get us the result quick quick, so we can initiate therapy? Sequential ADE, what does that mean? Instead of doing a lot of empirics together, how about doing it sequentially? Broad spectrum, but sequentially. Now, these are likely recommendations that could be suggested to the healthcare professional. Antibiotic de-escalation. We have pivotal antibiotics. These ones are critical to therapy. They are non-negotiable. For example, the beta-lactam antibiotics, the cephalosporins, and all the likes. We have companion antibiotics. These ones reduce or they broaden the spectrum of the pivotal antibiotics, such as daptomycin, vancomycin. These are anti-methicillin resistant Staphylococcus aureus. Now, for patients with positive cultures, now I want to do antimicrobial stewardship now, and I've gone to the lab. The lab is culturing, and within 24 hours or 48 hours of culture tests, it is shown that it is positive. It is suggested to perform de-escalation within 24 hours. It is suggested that you should perform de-escalation. What that means is narrow your spectrum of antibiotics to the sensitive one that was implicated in the lab within 24 hours. So, and then previous studies have reported that ADE is common in patients with microbiological established infections. Now, elements, I think we can just pass this slide. It's talking about the structure of the program of antimicrobial stewardship, the hospital leadership, the people on the team. The hospital leadership has to be committed because it's a committee. The pharmacist is not just entrusted with this task of stewardship. There's the medical lab technician, the scientist, there's the doctor, the physician, there's of course the pharmacist. They are doing different forms of activities. There's action, tracking, reporting, education. So it goes from one unit to the other. So it's a stepwise process. Now, I want to go straight to pharmacists in healthcare. What what are the roles of pharmacists in healthcare? Before we talk about the roles of pharmacists in AMS, we have medication dispensing and review. Pharmacists ensure that antibiotics conform to guidelines. There are guidelines that guide the prescribing, the dispensing, the use of antibiotics. Pharmacists also review patients' medication profiles. You should have access to review their antibiotic profile, to even ask the patient questions. Sometimes the doctors may be overwhelmed and lost on certain vital information. The patient may not tell the doctor, I've used cefuroxime, I've used it, I've used levofloxacin, I've used this, I've used this. So sometimes the doctor is not privy to certain information. So you counsel, you review their profile, you identify and check for possible allergies, duplications, and interaction. Education and counseling. Pharmacists also educate patients about compliance and the consequences of non-compliance. As pharmacists, we shouldn't just give them their drugs and let them go. There is need for us to tell them about the need to comply, to adhere to their medicines. Also explain possible adverse effects and when to seek medical intervention. Collaboration. Pharmacists should be active collaborators. This is what will help us preach the gospel of AMS. We need to collaborate. We need to collaborate with the person in the lab. We need to collaborate. Ask the person in the lab, which microorganism have you been isolating very frequently lately? Okay, people living in that area. It's like there's an outbreak of this. These are things that collaborative discussions will help you to fish out. The pharmacist also collaborates with the physician and helps to guide him when he's trying to narrow down on a particular antibiotic or antibiotics. Now, what's the role of community pharmacists also? Please, I want to advise, we are pharmacists on this call and also other healthcare providers, that we should always be available. These days, when you go to pharmacies, you see patients saying, please, I want to see the pharmacist. It's not because the pharmacist has sugar on their head or anything. It's because people need information. They want to be sure they are taking the right drug. They want to be sure it's the right dose. They want to be sure they are doing the right things. So there's a lot of roles that community pharmacists play. And most crucial of it is the fact that most people who are sick, they report to the community pharmacy first. So the community pharmacy is very accessible to a lot of patients. Pharmacists need to always be available in their premises of practice. Also, pharmacists should undergo quality continuous improvement. Pharmacists should learn to take courses. There's a lot going on as regards methicillin, vancomycin resistant MRSA. Like even vancomycin is now proving to be resistant to MRSA. These are vital information that you could always tell the health team, see what is going on, you know. So you should be like a knowledge bank. If we need, there's need for any information or updates in the world of antibiotics. Medication reconciliation. The pharmacist has to identify discrepancies. There could be discrepancies in medication regimens, and that's why a second eye is needed. Provide patient education, monitor patient response to medication. And that's the reason why you need to always be available. Sometimes some patients will say, they may want to call you to say, I'm experiencing this. I've been taking Augmentin. I find that I'm becoming weak. I'm becoming tired. It's the pharmacist's duty to educate the patient at the point of purchasing the antibiotic. You're likely to experience this. Watch out for this. Ensure you finish your drug. If you experience this, this is what you will do. So those are the roles of pharmacists in uh, the community pharmacy. Also educate other members of the healthcare team. Some people largely are not aware. So educate them. Guide patients in antibiotic selection. I know it's not the jurisdiction of patients to select. Yes, but sometimes they may tell you, that antibiotic, they scratch me, it's doing this, it's doing this. But sometimes you could guide them. Okay, if we're not doing this, can we do this? Does this react this way to this? Also, pharmacists should be aware of the unregulated use of antibiotics by livestock rearers. People come to buy antibiotics for their livestock and fowls. Also, pharmacists should frown at mixing antibiotics. Please, that should not happen. Polypharmacy is highly discouraged. Pharmacists should embrace antibiotic preserve approach at all costs. Let's try to be, unquote, stingy with dispensing antibiotics, especially in the community pharmacy. Dispense only when it is necessary. Now, restrictions in antibiotic prophylaxis, especially after exposure. Some people say, I just had unprotected sex. Let me just take this antibiotic. Please, except when it's absolutely needed, please discourage it. There are broad interventions that are also used. These are three out of some others. We have what we call antibiotics timeout. What does this mean? Antibiotics timeout refer to the time when, like I described the other time, the 48 hours, 72 hours, pending when the laboratory results is being released. That's what we call the antibiotics timeout. Prior authorization. Now, this is actually done by a member of the team of AMS program, and that's an infectious disease personnel who has to authorize the prescribing and dispensing of antibiotics. We also have prospective audits and feedback. AMS programs. Now, the sustainability of this thing weighs heavily on pharmaceutical interventions. This will require data. What kind of data? Antibiotic formulary, lab works, susceptibility patterns. We've talked about it that in some localities, there are some microorganisms that are susceptible to certain antibiotics and all the likes. So this will require data. We need a data specialist, someone who specializes in data collation and the likes. So this has to be made available to the physician for informed clinical decision. In turn, the pharmacist is a go-to person. The crux of this entire AMS program is that the pharmacist is a go-to person in terms of information. AMS programs take on a collaborative approach for maximum results. Now, AMS program is more important with the like I explained earlier, there is a decline in the number of new antibiotics molecules and the rates at which older antibiotics are being phased out and are returned to the shelves. You now ask yourself, a drug like ampicillin, why is it that we are not seeing it so much in the shelves? Most times most physicians now, there's this combination of ampicillin and gentamicin. You now have to combine ampicillin and gentamicin. Ampicillin alone may not give you that result, and that's because of resistance. So practical pharmaceutical interventions. What are these practical interventions? We've talked about antimicrobial monitoring. That's in the next slide. Discontinuation after 48, 72 hours of culture, continued therapy for positive microbial growth, and then we also have antimicrobial reassessments. We also have antimicrobial reassessments. Cease taking antibiotics 1 to 2 days after infections ceases. You see, so there is need for reassessment even when you're taking these antibiotics and infections have ceased. You cease taking them after a reassessment. How does this reassessment come? Laboratory tests. Antimicrobial selection. There is also need for the choice based on lab results, patient history, potential drug interactions, adherence. If you know that the patient is not going to adhere, if there are other options that will give likely results, we might want to consider that. What's the route of administration? Also, as pharmacists, we should try to avoid, in as much as we advocate for complete course of therapy, we advise that we limit the use of broad spectrum antibiotics. We advise that we know that, of course, we've mentioned this, that antibiotics should not be underused or overused, and that has to do with misuse, but also we should limit as much as possible. It pains me greatly. I have to say this, that sometimes we come to pharmacies, someone has a simple cough, without even running, maybe going for a cough sputum test or whatever. You see, they will just give augmentin quickly because we want quick therapy or quick money. I don't know, as the case may be. So it's there is need to preserve antimicrobial preservation. Like I said, pharmacists should be stingy with releasing antibiotics. Let's see them as precious. So insisting on relevant, okay, back to this point, I want to also say that the pharmacist, in his judgment, especially those in the community setting, there are certain times that maybe a drug like ceftriaxone may want to be used IM 1 gram, may want to be used for more than 3 days or 5 days. It could be that maybe the infection is reoccurrent, or it could be that it's quite serious, a serious kind of infection. You see, so also there is need for antibiotic advocacy. Let's preach the gospel of please run tests. In the community practice, always insist that patients run tests before you release antibiotics. Practical interventions too. As pharmacists, we are armed with the knowledge of pharmacodynamics and pharmacokinetics. And that property of a drug like vancomycin, we can maximize it. How? I will just say it briefly for sake of time. Vancomycin is a drug that has a very interesting pharmacokinetics. What that means is that in the plasma concentration of vancomycin is such that it is time dependent, but concentration independent. What that means is that you can keep giving multiple dosing of vancomycin. I'm not saying it's not going to have a lethal effect, but the way the drug is being released, it's having like a first order kind of kinetics. It's being released and is dependent on time, but on concentration, it is not. You get it? So it's easy to exploit and understand how we can maximize the PK and PD of vancomycin. And it's been reported that in patients who are big, vancomycin has been found to be inadequate in plasma. So that tells you that you could inform the physician that, okay, if we're giving this particular dose, notice that this patient is obese. So we might want to add up a little of this. So we will not be giving this patient subtherapeutic doses of vancomycin, which is a call for resistance. Collaborative approaches to combating antimicrobial resistance. Now, within our local spheres of influence, there are things we can do amongst ourselves as pharmacists. And that has to do with in-pharmacist collaborations, like what we're doing today. We're sharing knowledge. You see, we should learn to share knowledge. If there is a new update about a particular antibiotic, okay, we say, okay, we can use ceftriaxone. There are some kind of vaginal infections or some kind of, we think ceftriaxone is quite doing well in terms of laboratory sensitivity. You know, we could share knowledge. We could share experiences. We could share issues where antibiotics have failed that we have actually recommended for patients. It helps we help one another to learn when we do this. In pharmacist collaborations, I talked about that. Establishing patient-specific AMS records and record logs. It's important. I think this needs to be introduced into the hospital system. We shouldn't just have a record of antibiotics in their folders. Just like we have poisons book, control drugs, we should also have records of antimicrobial therapy of patients. Over time, it even helps you to monitor, okay, this person has been on Cipro, maybe last year, this year, how was the person behaving? What was the microbial culture and sensitivity test that preempted this? You know, all of that, it even helps in tracking. Exploring the pill count system, as difficult as this may sound, sometimes it's important, especially when we have patients who are not compliant and also patients on multiple antibiotics. We could explore more pill counts. Ensure as they come, maybe they are coming for a refill, maybe their second refill, you should count, okay, I gave you this antibiotic on this date. Okay, have you finished it? It seems you missed one day and all that. And also, as you relate with them, you hear them say things like, I missed my drug on that yesterday. Oh. I forgot to take it. So I didn't, because the time has passed, I didn't take it again. You, as the pharmacist, knows the pharmacokinetics of that particular antibiotic. You tell the person, okay, you should have taken it. Okay, you shouldn't have, based on the half-life, based on whatever of the antibiotic. So we should learn to be ask open-ended questions so we can learn and get to know what the patient has to tell us about their course of therapy, of organizing events with practical means of preaching the gospel of AMR and AMS. Conducting surveys. Okay, the last point there is influence, advocacy using the media. Some of us are influencers. We could take this gospel to the media, to the online community, talk to people in the best possible way. There is need for conducting surveys, prescribing patterns, implementing policies that will optimize antibiotic use. There is also need to get information of geographical susceptibility. In advanced countries, this is actually the trend. They get susceptibilities patterns in a particular locality. Enactment of regulations of antibiotic sales, especially in patent medicine stores. There should be regulations. Diversification and specialization. We should have pharmacists who their area of specialization is infectious disease and clinical therapy. More pharmacists directed antimicrobial stewardship programs. Collaborative approaches to combating AMR globally. We have global health bodies, AMR focused research and advocacy. A country like not a country, an international organization like, for example, FIP or some of these big organizations can say, okay, we want to pull up funds, maybe provide grants for pharmacists to do more research on AMR, AMS advocacy, research on how we can tackle this practically in hospital settings, in community and all that. Global AMR resource banks, there is need for this. We need to have resource banks, go to areas where, uh, for example, we have a global resource bank, maybe in the US, controlled in the US, but it has subunits that is region specific. Maybe for Nigeria, there's a branch for Nigeria. What they will do rather is that there is always a publishing of information on solely antibiotics, the current trends, what research is saying, the resistant patterns, and all whatnot. So, pharmacists should also champion World Antibiotic Awareness Week. This is a global event that is organized every year, in fact, November of every year. But I don't know how uh, how active that has been in our country, but it's a call for us pharmacists to step up and carry this thing on our heads, in a layman's word. So there is need for research to design more targeted therapy. What does that mean? Having therapies that are targeted to particular antibiotics. Imagine, for example, I take ciprofloxacin when I'm not supposed to take it. And because there is no need for ciprofloxacin, the drug is null and void, it doesn't work in my system. Or I take a broad spectrum antibiotic like augmentin, and when I'm also, maybe I take augmentin when I'm supposed to just take simple, maybe amoxicillin or something very simple. I went as far as augmentin. Now, what I could do, what that targeted therapy will likely do, is that it will focus on the particular germ that it's meant to eliminate and stop there. That's targeted therapy. We have a lot of this in cancer chemotherapy and all other fields of nanomedicine. But I feel if we can embrace this in antimicrobial resistance, it will go a long way. Exploring policies that strictly classes certain antibiotics as POMs, for example, meropenems, vancomycins, those antibiotics need to be protected, unquote. So instituting antibiotics other forms, we've talked about this, antibiotics timeouts for hospital systems. Then next we'll be talking about there is something the Center for Disease Control developed. It's called antibiotic use as part of National Healthcare Safety Network. Now, what AU does is that it collates data and monthly reports for the duration of therapy, and it aggregates it by specific agents and specific regions. Now, this module is available to facilities with capability to submit electronic medication. What is this trying to tell us? That it has come to a time where hospital systems, clinic, healthcare providers should come together, have electronic records, not just paper records, electronic records of their antibiotic dispensing, prescribing, and have these records submitted, and such that this data can be collated and can be monitored to provide, or to there can be submitted rather, and it will help to monitor and track the use of some of these antibiotics. And it also helps to guide the logistics chain. What are the barriers to AMS programs? Ineffective follow-up. And it sometimes can be overwhelming even for the pharmacist. It's not easy to say you're following up on, because on a daily basis, a majority, like 70% of people visit hospital may go home with one antibiotic or the other. So it's always been prescribed. So imagine the overwhelm of having to follow up with each patient, you see. So ineffective follow-up, we need to come up with strategies for following up antibiotics, people on antibiotics. Then uncontrolled infection source. For example, maybe people not practicing hand washing, and you see there's a widespread of dysentery, of salmonellosis, and all that. So when the infection source is not controlled, people are not washing their vegetables, or the water source is bad, these are challenges to antimicrobial stewardship, because whether you like it or not, they will take antibiotics. So lack of patient-specific information. Sometimes there are not information that are specific to patients. We say, okay, people in this locality are just having diarrhea, vomiting, they all have food poisoning, and there is no need to run any test or whatever. We just carry antibiotic and give them. These are all challenges, You see, so but when we have therapy that is tailored to a particular patient, this helps a lot. Lack of robust laboratory system for rapid diagnostic tests, we've talked about this, that time is very critical if we need to make informed antimicrobial decisions. Poor adherence, we've talked about it, that there is usually poor adherence to drugs. A typical Nigerian is always looking for the shortest therapy possible so that they can be on their way. Benefits of antimicrobial stewardship. Statistics have shown that there is 80% reduction in treatment failure. You see, so imagine that therapy is patient specific. We have data for every patient that comes into the hospital. We have history of the antibiotics that have been taken and all that. So it helps to do a lot of good in treatment outcomes. So we'll call it a day from here. I'll be willing to take your questions. Thank you.
Thank you very much, Opalago. I must say this has been a very, very interesting, exciting, eventful presentation. Thank you for a very thorough work done and for the explicit knowledge you've shared with us this evening. I think this was very, very extensive and a very good value for our time. So, ladies and gentlemen, I would want to give an opportunity if there are questions we have, if anybody has a question so that we can hear from Lillian, okay? So someone is asking, this is Ade Mola Omolara Comfort. He said, thank you for the wonderful presentation. When you have a patient in the ICU with multiple antibiotics, how do you handle this to prevent drug-to-drug interaction? Did you get my question? Hi, Lillian. Did you hear me?
Okay. Says when you have a
Is it when you have
yes, I
a
can hear
patient?
you.
Yeah, when you
So
have
it
a patient
says
in
when
the
you have
ICU with multiple antibiotics, how do you handle this to prevent drug-to-drug interaction?
okay. Thank you very much, Ademola, for your question. Now, when usually people in the ICU are critical, they are people who are having critical conditions, and most of them, like I explained earlier, come down with nosocomial infection and the likes. So there is need for urgency. There is need for urgency. And sometimes, like I explained, the laboratory results may not come in time. So your question is how to handle this to prevent drug-drug interaction. Now, the first thing to do is to sample the antibiotics involved, is to sample them. I don't know the antibiotics now you are referring to, but if these antibiotics are, of course, most of them will be broad spectrum, because they're trying to cover a lot of things which are yet unidentified. So there is need to sample these antibiotics one at a time. If the patient is on, for example, say IV Rocephin, or the patient is on tinidazole infusion, or the person is on metronidazole, or I don't know. So there is need to sample all of these antibiotics and critically take a look at them to observe for drug-drug interaction. Now, because I'm not sure of which antibiotics you're trying to refer to, it's important to sample them and then check. But I'm sure antibiotics is also important to check for the age of the patient involved. If, for example, maybe it's a child of say 3 years or so, you are now faced with the option of giving maybe gentamicin, which is quite dicey. You see, but gentamicin might be important, but you have the risk of nephrotoxicity, ototoxicity. So you're now weighing your chances. Can we do gentamicin? Okay. Can we just substitute it with maybe another aminoglycoside? Can we do streptomycin? Or is there another one we can switch together with this? You know, this is a time you will now ask questions. Why I'm saying this is because gentamicin, of course, in children should not be administered. But sometimes we weigh the risk as against the benefits. So when we are checking for drug interaction, we should also be aware of the fact that this patient is critical. So as much as possible, we want to give less drug, but with more antimicrobial coverage. So drugs that cover both gram-positive, gram-negative microorganisms, large coverage, but less antibiotics. But in the event that we have multiple antibiotics, it's important for the pharmacist to sample all of these antibiotics and observe for possible interaction. Thank you.
Laura, you're muted.
Sorry, hi, Onye. I couldn't join earlier. I had a bit of network issues. I'm sorry for that. So thank you for your wonderful presentation. As they say, it's teaching time saves 9. So I believe if we all join hands to solve this menace called antimicrobial resistance, it will go a long way in increasing therapeutic outcomes. So I don't know if any other person has a question for her. Okay, I think there's a question from, okay. The overdiagnosis of typhoid is alarming. What do we need to do collaboratively to arrest this ugly trend, as it remains one of the most common sources of antibiotics abuse and misuse in our climate? Amonde, did you get that? Hi, from Lillian.
Yes, I did.
Okay.
So I can hear you. I got it.
Okay.
Okay. The thing is, a lot of and where we need to educate patients. People think that once you have malaria, there's typhoid, and we put it, the overdiagnosis of typhoid. And I hope it's a diagnosing and not a patient, saying I have typhoid malaria. So in the event that it's coming from a let me come from the aspect of maybe it's the patient thinking that he or she has typhoid. So you're asking what pharmacists need to do to collaboratively arrest this ugly trend, as it remains one of of antibiotics. Now, what we can do is always people to go for tests, or we play on a safe side. I usually advise or advocate the use of simple antibiotics like amoxicillin, but not to say someone has typhoid. Let me assume it is true. Not to say someone has typhoid and we go as far as giving augmentin. You get. So it's usually advised to play safe, possibly with the lesser. Remember, our aim is to preserve antibiotics. Let's begin with something as simple as amoxicillin. Because sometimes when you don't give people these antibiotics, they feel like you've not arrested their problem. So first off is to reassure the patients that everything is all right, and as much as possible, encourage them to run tests. Let's be sure, let them run wide-out tests. Let's be sure that this is actually the case. So in the event that is the case, let's play safe. Give simpler antibiotics, except it's an established case of salmonellosis, or what Nigerians call typhoid. Thank you.
Okay. Your name isn't Shane. Redmi no top. I hope your question was well answered. Please, is there any other question for Familia before she goes?
I think there's none. We rather have a lot of positive feedback. Somebody said,
There's one from Ugo Nasi and Yokete. He says, thank you so much for the presentation. And then from Ahmed Yakase, says, thank you fantastically. Thank you for fantastic presentation. Very rich and comprehensive as it touched all areas concerned. You have answered all the questions in my mind, and it is good to advocate and promote more researches in new antimicrobial combinations and new techniques. You are highly appreciated. Thank you to Yakase. We're saying a big thank you for joining us. Lilian, someone is giving you a very big commendation for your presentation.
Yes,
Thank
and
you. Thank
also on
you.
our YouTube stream, we have Joel Taiwo is
Thank you.
greatly educating. Thumbs up to the presenter. Same thing from Ada Sunday. This is really informative and interesting. And yes, so that's basically all that we have. So I think clearly we can say that we've had a very successful learning evening. Thank you once again, Fam Obalaku, for coming to do justice to this topic. And I'm sure our listeners will be glad to have you once again come, share on another very interesting topic and share your wealth of experience. Thank you for obliging us the opportunity to learn from you. Thank you from Laura also for supporting again this evening. We really appreciate it. So from us from EHA Clinics Academy, we want to say thank you everyone for joining us. This recording and presentation and the presentation slides will be available on our EMR, and we'll reach out to everyone else via emails where we registered so that you can have access to this that has been shared. And so that'll be all from us. Good night, everybody. Thank you. Do have a good evening. Bye.
Thank you very much.
Okay, bye everyone. Do have a nice night.